forward.
speaker.
Yeah. So I again request Dr. Sandeep Hedgire to come on dais to deliver his talk about post-procedure imaging, including complications.
All right. I feel like this morning you're going to have a Sandeep overdose. So my next talk today is post-procedure imaging, including complications. We're going to see what are the percutaneous valve interventions and what can go wrong during those interventions, best way to detect it, and we'll gather a lot of imaging findings as we go through these cases. Please know that not all valve interventions go as smoothly as Dr. Bala showed, so you will see plenty of examples in my talk about device-related or systemic complications of these interventions. These device-related complications include malpositions, migrations, thrombosis, paravalvular leaks, fistulas, infective endocarditis, compression of adjacent structures, and we'll talk about some newer procedures. Systemic complications are similar to any vascular access, particularly hematoma and pseudoaneurysm and stuff. We touch base on the valve-related CT protocol. If you are entertaining a complicated valve intervention, then it's important to know where is the suspected complication, so you can decide your Z-axis coverage. If you are going to scan the whole chest, abdomen, pelvis, we typically like to start with non-contrast of the heart, followed by non-contrast of the chest, abdomen, pelvis. These non-contrast images are extremely helpful to detect. Many times, if the question is where the device go, did it migrate? Just non-contrast is enough. But sometimes you need contrast to identify where exactly the device has malpositioned. So we obtain a ECG-gated CT, which is retrospectively gated of the heart. Then we do a non-gated CTA acquisition of the chest, abdomen, pelvis, and that's followed by a 100-second delay. This 100-second delay is more for systemic complications. Sometimes you can pick up active extravasation and stuff. I already mentioned contrast injection protocol in my earlier talk. So here is a little snapshot of how our injection protocols are phased into 3 different phases of injections: pure contrast, contrast saline mix, followed by pure saline, as indicated before. The gating by default is retrospective for these kind of scans. Very rarely we get requests to give as little as possible. So here is an example of a TTVR planning CT that we have done with 20 cc's of contrast. The way we do it is we do a retrospective acquisition, which is much shorter acquisition, and then because we have restricted amount of contrast that you can give for this particular patient, your strategies are to increase your table pitch that will decrease your scan time, or use a retrospective gating. All right, let's take a deep dive in some of the complications. So first case, here is a patient who has very large tricuspid annulus. When I reported this, there was a certain sense of disbelief that no, there's got to be something wrong with the measurement. And but I was pretty certain about my measurement, but the person didn't believe me and chose the valve of a different size. And on the follow-up echo, you can see that this valve has now fallen down at the base of the right ventricle that you can see on the echo. And then the only way to rescue this patient was to take the patient to the OR and do a sternotomy and do a new valve, which defeats the whole purpose of doing a percutaneous valve planning procedure. Moving along. Next device I'm going to show is a mitra clip. It's a widely used device thought to be highly successful in treatment of mitral regurgitation. When mitra clip is placed, it's supposed to hold both the leaflets together, thereby reducing the coaptation gap of the mitral valve. But not all the time this goes well. Here is an example where the mitra clip did not go well, and you can see that this is fine here. But if you look at the valve on cine images, you can see that the anterior leaflet has gotten detached from the mitra clip and is prelimobile, and thereby reigniting that mitral regurgitation that the patient had. Sometimes mitral clip can migrate too. Here is an example of how the mitral clip migrated at the level of the aortic root and got stuck there. CT, non-contrast CT is good to see where the device is, but sometimes for precise identification, you need contrast on board, and this is an example of that. The mitral clip migration is thought to be rare. Here are two X-ray examples of how migrated device can look very different on X-rays, but not only smaller devices migrate, larger devices can migrate too. Here is an example of a migrated TAVR valve. So when the TAVR valve migrates like this, there is a technique called lasso technique where they are able to snare the valve sometimes and bring it back to the original position where it's supposed to be, but sometimes that's not possible. And when it is not possible, your only option is to place a second valve at the level. Most of the patient, according to the literature, who have had this complication, they do fine in the long run, but it sounds very scary in the first run. Here is a patient who's a 68-year-old female who had a patent foramen oval, had a stroke. They decided to close the PFO by placing an implanter device. By the way, anybody is looking for inspiration in your life, please go look at Kurt Implanter's biography. He applied for 30 medical schools. Only one medical school took him, and that's where he made his entire career and found a lot of the newer advances. So a lot of inspiration there. Not to digress, coming back to this migrated implanter device, and the question was, where did the device go? Because they did an echo and didn't see the device. So we decided to do a CT, and we found the device lodged at the level of the proximal abdominal aorta. When we talk about TAVR, sometimes when the TAVR valve is placed, we expect that this will look like this, where there is absolutely well-positioned valve without any thrombus. With time, though, sometimes you see these areas of hypodensity come circumferentially along the valve, and this is how Panus looks. So this is a fibrous reaction of the tissue because you have placed a valve there. It is important to note that we need to distinguish this entity from thrombus. Here is another example of this was actually read as Panus formation. I carefully looked at it and measured the Huntsville units, and I said, this is not a Panus, this is a thrombus. So the question is, how the hell do we distinguish thrombus from Panus? The Panus is a more diffuse process. Thrombus is a very focal process. Panus tends to have a higher Huntsville units of greater or equal to 145 Huntsville units. Thrombus generally sticks to less than 90 Huntsville units. And Panus usually does not require an intervention, but thrombus does require thrombolytic therapies like anticoagulation. Another important concept in the TAVR world is understanding what is the neosinus and what is the anatomical sinus. Neosinus is the sinus of the valve that has been placed, but you're not getting rid of the anatomical sinuses, which are on the outer aspect of the valve as shown here. And sometimes these anatomical sinuses do get thrombosis because there is a communication, as you see on these schematics. This thrombus can then migrate to other parts of the body. So it's important to pay close attention and report that when you see it. HALT was mentioned in the previous talk, so I just wanted to share something about HALT. So this is a patient who has HALT, stands for hypoattenuated leaflet thickening or thrombosis. When there is HALT, it can be graded according to the percentage of HALT, and it's best done on a 3-chamber or a long axis fuse. So this patient's HALT was graded as 75% of HALT. When there is HALT involved, you have to pay close attention to how the leaflets are moving, because many times it is associated with restricted leaflet motion. So that stands for RLM. So your patient may have HALT, but very little RLM, may have both of those things. So it's important to mention both in your report. Most of these patients do fine, and once they are placed on anticoagulation, it typically goes away. As I mentioned, not all TAVR placements go smoothly. This is a patient whose TAVR placement was complicated because of the balloon dilation. This patient developed an aorto to RVOT fistula that you can see on these CT images right here, which was confirmed on the echo as well. And then the, the, the shunting was so much that it was a decision to close this the fistula with a plug. And so we did a CT and we provided these gantry angles for the team, and those gantry angles are highlighted in the yellow box there. So based on that, they were able to salvage a lot of time in the cath lab when they did the procedure. And here are some pre and post placement of the plug, which closed the defect itself. Paravalvular leaks are important. If you look in the literature, the literature says they can be concentric, oval, roundish, perpendicular. So basically, they can look like anything. So what is a paravalvular leak? Paravalvular leak is a streak of contrast channel alongside the valve, which is pushing the valve back, pushing the blood flow back alongside the outer aspect of the valve that has been placed. Now, it is important because this can precipitate congestive heart failure. As the RBCs in the blood cross this valve, they get damaged. So patients can have hemolytic anemia. When you're trying to close the paravalvular leaks, it's important to provide some gantry angles, unlike the last case I showed, that will save time in the cath lab trying to identify this paravalvular leak. Sometimes the leak is very apparent, as shown here on the cine image. There is a large gap here between the mitral annulus and the device itself. Please note that paravalvular leaks can happen both in surgically placed valve as well as catheter placed valves. Infective endocarditis is much more common in the prosthetic valve setting. As I mentioned, you can see a lot of imaging findings, particularly vegetation, pseudoaneurysm, abscess formation. You can also have aneurysm formation. Valve leaflets can undergo perforations. You can develop fistulas. The valve can dehisce. You can have rocking motion of the valve, and you can, of course, develop paravalvular leaks. In the United States, most common pathogens are Streptococcus viridans and Staph aureus. And here are some anatomical images of the CT scan of this patient who had a prosthetic valve. You can see multiple findings of infective endocarditis here. These are the vegetations. You also see two pseudoaneurysms at the same level, and you see a large aortic root abscess. It is important to know that to review the valve itself on the cine images to see whether the valve is rocking or is well placed, because that's going to decide the surgical options and whether they want to replace the valve or just treat it with valve sparing approach. Sometimes the abscess is so big that it compresses the left main coronary artery, and the patients present with acute chest pain. Here is an example of this video, please. Here is an example of a rocking valve that is about to go for a ride any minute because there has been an enlargement of the root as a result of infection, and there is a large paravalvular leak as well in this case. Sometimes the question is, these patients, particularly in the pseudoaneurysm is small, they get placed on antimicrobial therapy, and the question is there still active inflammation? So as a follow-up, PET can be very helpful to see if there is an ongoing infection or inflammation there. And here is an example. So these two scans are done 6 months apart, and the patient, and when we did the follow-up PET after 6 months, the patient was still having episodes of fever, and on PET, this area did light up. Please note that if you are doing this, particularly for heart valves, PET requires special preparation because you want to suppress the myocardial FTG uptake. So we give high-fat diet for PET when we're doing this. Here's a patient who has a mitral valve already placed in there. You can see the arrow indicate a small paravalvular leak. In the process of somebody trying to fix a paravalvular leak, there was a large pseudoaneurysm that developed, as you can see here, and then they attempted to close the pseudoaneurysm by placing in a Platzer plug because the patient was not a surgical candidate. And he was very old, and the only way to save the life was to place an Platzer device. So know that this is one of the indications of a Platzer device, particularly if the patient is not a surgical candidate. Basilica procedure was mentioned. So basically, the goal is to maintain the coronary flow. But sometimes the basilica procedure doesn't go very well, and Here is an example of failed basilica procedure where you can see active extravasation during the basilica itself, and so they suspected that the aortic root had ruptured, and they brought the patient for CT. We couldn't identify the definite rupture. Probably the rupture was very small, but we did identify a lot of blood in the pericardial space as shown on these images. I mentioned coronary anatomy with relation to the RVOT in patients who are undergoing transcatheter pulmonic valve placement, and fortunately the incidence of complication of coronary compromise or compression in TPVR is low, with rates as low as 1 to 2% according to the Melody registry. The thing that you need to watch here is the relationship of the coronary artery, either anterior or posterior to the RVOT or the pulmonary artery. This is a patient who has a pre-pulmonic course of the left coronary artery, and this is something that you do want to mention in your report. So as I mentioned, this complication is rare, and then both with the SAPIEN as well as Melody registry, the rate is very low. I want to say a couple of things about when patients have more than one valve that needs fixation and they are not operative candidates. So please note that there is only so much space available in that LVOT area. When you place two valves there, there's barely anything left in that space, and as a result of it, sometimes you have to lacerate the leaflet to maintain the blood flow across the LVOT. But when you do that, the patients are prone to develop a paravalvular leak, which is what this patient had. Lastly, I wanted to mention access site complications like hematoma, pseudaneurysm. Ultrasound is a great test. Even a bedside ultrasound can diagnose a hematoma. If you find a pseudaneurysm, you can offer bedside compression of the neck of the pseudaneurysm, compress it and thrombose it. But sometimes it's not compressible, particularly in a large patient. Here are examples of pseudaneurysm, active extravasation, and a large hematoma. Many times when these patients come to us, there is a prior scan available in the system. So if you are looking at hematoma, not at the access site and some other site, you need to ask the interventional cardiologist, did something go wrong during the procedure? Did the wire go astray and damage some of the structure? So here is an example of a patient who had a retroperitoneal bleed, and when we reviewed the CT, this was unfortunately missed in an outside hospital. This patient has fibromuscular dysplasia. These vessels are weak. So this is a vasculopathy, and when the vessels are weak, the walls are weak, and then they get damaged during the percutaneous procedures. The access site complications are much more common in women, unfortunately, and particularly at the site of the vascular access, a lot of people are now using closure devices which help to prevent some of these complications. And I just want to say thank you to my entire team at Mass General, and thank you IACI for inviting me to come here and share some of the work that we do. And happy to take any questions.
Thanks, Sandeep. Brilliant talk. And, you know, I want to put these two talks together. And since Dr. Bala is here, I'm very glad that he's here to see this. When you talked about the heart team, you said the cardiovascular imager, you said the interventionalist, and you said the surgeon and whatever else. What you missed out was the Tremensio reader that you all have. You get me? And the thing is that what I wanted to highlight, and I forgot to say it at your point, and this exactly was showcased in Sandeep's talk, where the fibromuscular dysplasia will never be picked up by somebody who's not reading it. So what invariably happens is that one set of images goes to the person who takes it to the Tremensio. He comes back, he gives you the answers to all the questions, gives you the report, and a lot of cardiologists in India are unfortunately following that number and using the valve. And then, you know, this whole gamut that comes out, which Sandeep has just highlighted from A to Z, that, you know, everything doesn't go right. And how more than not only along the course of the aorta and the peripheral vessels or the aortic valve or the aortic root, more than that, it's also everything else in the, you know, in the person. Sometimes there's a pheo that's been missed, or there's fibromuscular dysplasia that's been missed, which if one had some idea about, one would have been more careful or something. So I think it's really important that when we're reading the TAVR, there is a lot of things outside just the entire TAVR read. And that's what needs to be highlighted, and that's where the radiologist comes in. And it's very important for each of you to know that when you are an imager and you're actually reading for TAVR, there's just more than just reading the aortic root and giving the sizing. Any questions?
I 100% agree. In my hospital in Boston, we have, as I mentioned before, we meet twice a week. There is every case that is undergoing TAVR or TMVR, TPVR, doesn't matter the type. Every case, echo, CT is reviewed together in a multidisciplinary approach, and we warn them ahead of time if we see something that might complicate, as Mona said, we've picked up masses, we've picked up aneurysms, vasculitis, all sorts of complications. Absolutely. So,
I mean, I've had a patient who went into the OT and they were going to, they said that, okay, this patient is not for TAVR. We take him to the OT. When they opened the OT, they realized that the whole aorta was in a bad shape just because nobody else ever read it. And you've got aorta arthritis all along, and there's no chance that this patient really can be operated. So I think there's a lot of things that can be looked at. And not only TAVR, but I find even now it's the surgeons that we're seeing who pre-CABG are actually evaluating it. Like yesterday we had this discussion, in case you have if you have bridging, or where is it the landing zone is going to be. So I think there's a lot of things that are happening in cardiovascular imaging, and we need to really bring it forward and showcase it so that we have the stakeholders who understand what is the true worth of the CT scanner.
One more comment I wanted to make, and this is something that we are incredibly proud of. So we have a 3D lab at Mass General Hospital. So when we hired the 3D lab techs, the first 1,000 cases that they did were checked by me and a colleague of mine. And they have gotten so good at this point of time that our intervention cardiologist said, forget the industry report, what did our guys say? Every single case that has a discrepancy has proved us right. Because you have to realize that the people who are doing these measurements at these companies, they have very little knowledge. Your radiologist is much more knowledgeable about these things and has a better understanding and better way to measure things, rather than a person who's not a radiologist but just a tech sitting in a company office. They don't care. They just give you what is their task is to generate a report, right? But your task, but ultimately it's you who are responsible for the well-being of the patient. And as a radiologist, we have the job to do our duty as well, to serve our patients.
Yeah, you'll have all the three on your meeting, and all the three will size us differently to fit their valve. And when my valve had a larger, you know that, right? Now you'll find everybody saying mine fits her, mine fits her. The core valve guy will say no, the height of the coronary is so much, and somebody else will say no, it's so much, and the my valve will say mine fits the best. So the whole game that over there is very different, because he's on a target to sell his valve, and it's your decision, because finally the noose is on your neck. So it's really important to understand it. And not only that, even the person who's sizing only takes one sequence with him. He only takes the flash, right? He takes the post-contrast flash. He doesn't even have that porcelain aorta that you showed, Dr. Bala, right? So he doesn't even know where the calcifications are. He's just got one sequence. Yeah. Yeah, absolutely. Yeah. And then they look at me and they say, which one did you get? Like, what do I put? So it's like that. So finally... Budhyavan, now the whole game is in your...
They always discuss with us. So even before sending the case, I get a call saying that we are sending a case for TAVR evaluation. So it's not like that. So I give a comprehensive report. It doesn't matter whether the CD is going to a company or not going to a company, but I give my report with all the measurements and everything that is required for TAVR. It's not like I just scan the patient, give off the CD, and then close that. No, it doesn't happen like that. So I give all the measurements and everything with all my report. And if there is a discrepancy, then I get a call back saying that, so is it really so? So sometimes, for example, as ma'am said, the coronary heights, so they say a different measurement comes out of the company, then I get a call, so this is the case, is it so? So I just say, no, that's not the case. This is the right measurement.
I think the other problem is that they're using automated software. They don't realize what is center line. They don't understand anything. They don't have basic understanding of reading. We, on the contrary, are reading it from base images. So that's where the problem comes. If you give it to any automated software, that's where they sort of read by themselves. But we have another super expert who wants to make a comment. Dr. Zishan, over to you.
Sandeep, is there any cutoff where you don't recommend going for TAVR? Of late, our surgeons are asking if the diameter of aorta is more than 5 centimeters, they would not take the patient for TAVR.
No, we don't have.
There is no such recommendation, right?
No.
Just wanted to be sure.
I think the techs who measure on Trementio are basically just technologists who are not aware of the procedure or what CT is or what contrast soft tissue, whether there is an hematoma on the side or whether there is a pseudoaneurysm. None of those important points would be given. They have just been taught how to go step by step in a particular fashion. So they just have been taught to put 3 dots here, press next. Then you identify the annulus, put 3 dots, press next.
Yeah.
So I don't think their values are anyway going to be very close or be the addition of amount of knowledge we give in addition to just the sizing is vast. And if you are really good at it, your cardiologist will soon realize. And like Dr. Mona said, nor in her department nor in my department, none of the structural imaging reports go without a complete report. It's not just the CD that goes out. And unless our reports are jotted down, the consultant does not take the patient up on table. And there are occasions where the valve guys actually cross-check with you, like what valve size have I got, before they commit a size to the consultant because they're so scared of discrepancies. Yeah. So I think if you get better in what you do, I think there is no comparison. There's no comparison at all.
Yeah.
Totally. And not only that, bringing in the point of techs, it's really important to have your tech really well trained. That is absolutely important. It's like what Sandeep has said, the first 1,000 cases, that's so important. You know, sometimes like the first talk that Sandeep talked about, whether you put your ROI in the ascending or the descending aorta, there's times when my tech will not even put an ROI and will start the scan when he needs to start the scan because he wanted to see the pulmonary artery, he wanted to see all the 3, you know. So it just depends on how good is your tech. So really get them hands-on and they must know what they have to do and when, because you can't be on the scan all the time and they need to be trained to that level. Yeah, Dr. Bala, you wanted to say something?
The same thing, ma'am. Last case, we had a patient with septal bulge and I given to multiple companies also. Finally, each told, okay, we can do it. So finally, I had experienced septal bulge. My colleague's case, I had popped out with the self-expanding valve. So finally, I had to go with that. Then I asked them, no, some chance of para leak might be there. Then went to the balloon expandable, then everything is fine. So always it's an individual decision and it's maybe like a discussion.
We had a situation, one valve gets put, the other 2 company wallahs left. They were halfway down the Delhi, you know, and imagine this valve popped out or some issues happened. Then we had to call them back, we need the other kind of valve. So then you call them back. So it's like a lot of chaos happens. So for sure, you need to pre-decide this and have it really astutely done. Any other questions?
I think there was a question on the app.
A question is there by Vidushi Gupta that it's from the first lecture. Should we label a patient as having regurgitation if we find regurgitation on Q flow but not seen on as a jet on cine images?
Yes, we should.
And you know, PVR.
Yes, we should. Yeah. Yeah.
So when we're talking about regurgitation, there's a lot of PVR, pulmonary valve regurgitation that we're now looking at because these are all the children who were TOFs who were operated back in the 90s. And now we have them all coming with RV dilatation and PVRs and all that. And so we really need to understand it and have a very good delineation of it and know how to image it well. Yeah. Thank you so much. Thanks, Sandeep. Great talk.